So thank you to my colleague, first of all, because now I know even more about this strange category of pathology, because being a VRS for me is very mysterious, because every time you read the paper and you see anterior segment, you change the page, you turn it, and you say, oh, that's not important, it's not for me. But unfortunately, the devil is still there. It can happen even to vitreoretinal surgeons. So for the definition now, we can switch to because everything has been already said. The common causes is this. This is the table that you can find in literature. But remember that every time you use something new, you have to append to this list something more, because everything almost could be related with this toxic anterior segment syndrome. So what is also important is the environment in where a cluster, because usually tests spreads in clusters, so you don't have one case or two cases, you might have many cases, so I mean 10 to 14, this is well known. And the environment is very important. So my environment is then an ophthalmology unit that perform anterior segment surgery procedures in 5 different locations. 2 of them have also the facilities for vitreoretinal surgery and other surgeries. We are in 8 surgeons. The environment is the same. So the same means that when I started directing this unit, I had in mind that it was much simple to make orders and to organize the work for all my colleague having the same material all over, because if somebody gets sick, he have a fever, so you have to substitute him with another surgeon, and it is very important that everybody have the same technique, the same material, the same nurses, the same training, and so on. And this was, for me, very lucky, because with a TAS, it's fantastic, because you just have to select what is new, okay? So this is the environment again. This is the number of procedures we do per year, more or less. Okay, so let's go to the report. So from July to November 2016, I have 14 cases. 11 was phaco, and 3 was combined procedures. So vitreoretinal surgery for common pathology. I remember there were 2 macular hole, 1 Packer's. And all these patients had no symptoms at all. So most of them wasn't absolutely with a white conjunctiva, with no light reaction or nothing like that. Okay. And all of this 14 patients happened within 24 hours from the uneventful surgery that I had. After the first 3 cases, I immediately think about the use of cefuroxime in the anterior chamber, because I used the off-label one, because aprocam was not yet disposable in my region. So I changed it. So I changed it to vancomycin, because before we used vancomycin, and I started to use my Dratix, because I think that's probably there were some strong maneuver made by one of the colleagues. And in August, there were no cases. But unfortunately, in August, we reduced our activity from to 50%, more or less. So statistically, it was absolutely difficult to understand if it was the end of the cluster or just a reduction in the number of patients made, and so the reduction in clusters going on. In October, immediately we had a peak. So September, October, we had another peak of this cluster. So we held a task force, 12 people, epidemiologists, the risk manager of the hospital. And we checked, as in literature they said, the whole procedures from A to Z. It means where the patient go, where he sits, what is the dropping that you use to dilate him, what is the way you clean up your instruments, the packages, the disposable material. It's a very long, very difficult analysis that you have to do, and usually is not an ophthalmologist matter. So it needs to be something held by a task force, okay? At the end, we decided to stop by these findings to stop the use of new packages we had for the disposable material, drops, cannulas, etc. Why this? Because the cluster spreads in 3 of the 5 hospitals. In 2 of the hospitals, we didn't have any case on 14, probably because we analyzed in those hospitals we used to use a stock still there of blades, of small, cutters, 2.2 and the strange things was also that in June we saw that with the packaging, and inside the packaging there were the blades. Some blades was very bad, so we asked the company to change them. So we asked it in June, and in July, the new blades arrived. So as you see, this is the synoptic table of the cluster. So the new cutters arrived in the early July, and immediately we had 3 cases. Then we had the summertime stopping activity, and then after the starting again of the activity, we had the big size of the cluster. At the end of November, we stopped with the new blades, and also the cluster stopped, okay? This is a electron microscope photography of a very costly but very diffuse blade that you can find on the market. And this is what we had. Instead of the one that were not sharp, we had this. And this is the magnification. Okay, the magnification shows kind of Emmental-like blade. I don't know how they can reach this this condition. And if you increase the magnification, you see that around the holes in the inferior side, you see all these whitish spots that we really don't know actually what the hell they are. So I'm still asking myself what they are. But of course, nobody of us would like to have one of these blades in his eyes when they submit to cataract surgery. In conclusion, okay, very likely to be cataract-related, no more cases till now. We are rejecting all the material. The procedures are very difficult because this material is bought by the public health care. All the patients are perfect, so they didn't have any trouble. I know, and I knew that sometimes you might have glaucoma, you might have the necessity to have DMEC, a substitution of the endothelium, because could be damaged, not our case. We have to reconsider absolutely in the parameter of the quality in the call to tenders when we decide what to introduce in our work. And also, by my personal point of view, it's necessary to have a task force national, as the USA has, because it's a very difficult work. So I spent really one very difficult month in September. So I don't want to see it again, because you have reunion, you have to turn around with a lot of people, you waste a lot of time, and it is very scaring, because you don't know when is the right moment to stop your activity, because sometimes you need it to stop, okay? Okay, that's all.
Thank you. This stresses the point that you are in the responsibilities, and you must be the detective who's searching all for this trouble. And so I remember we had 1 year, we needed to find out that the reason for TAS in our clinic was not to instruments or viscose or whatever, but the water supply, the tubes that were going to the sterilization room, that they had endotoxins. And the reason for this was there were blind tubes, and sometimes obviously something washed into this, no filter, and nothing could help but just new tubes that had to go there.
We checked also the tubes, and also inside the autoclave there are the filters, in which organic material could be somehow, separate and isolate, and it is very dangerous. But wasn't the case, because all the filters was already changed.
But it's very obvious that it's electron microscopic particles or some toxic substance that's soluted in the eye. Thank you.